Hello, and welcome back to What Now on the Threshold of Life, Death, and Grief. I'm here today in the studio with my friends and colleagues,
David Kennedy.
And Red Keating.
And I'm Julie Brown. And we are very fortunate today to have two guests with us, Jill MacPhee and Sarah Brisbin. And we're especially lucky because this is their second time coming to record an episode with us. And the first time we had some sound issues. And so a really warm welcome, Jill and Sarah, for coming back and spending this time with us.
Thank you. Thanks for having us back.
I'm going to read their bios and then we'll jump into some conversation. So Jill MacPhee holds the position of Director of Clinical Operations at the Kawartha Centre, previously known as the Kawartha Regional Memory Clinic. She holds a Master's of Science in Occupational Therapy from the University of Toronto and is a certified clinical research professional. She has over 20 years of experience working in geriatric health, specifically with individuals with Alzheimer's disease and other forms of dementia. Jill is also a research coordinator with extensive experience conducting neurocognitive assessments. And Dr. Sarah Brisbin shares the role of medical director of the Kawartha Centre with Dr. Katie Krause, where she provides medical assessments and clinical trial oversight. She is a fellow of the Royal College of Physicians and Surgeons of Canada with certification in internal medicine and geriatric medicine. Dr. Brisbin received her Doctor of Medicine degree from the University of Toronto before heading west to obtain her residency training in internal medicine at the University of Calgary. Dr. Brisbin also works with the inpatient geriatric medicine consultation group at the Peterborough Regional Health Centre, as well as throughout the area with the GAIN team program. So, welcome. So that's a little bit about their backgrounds. Let's dive into some conversation. When we extended this invite to have this conversation, the three of us, the co-hosts, wanted to expand our conversation because we're so often talking about in the palliative journey, like conditions and diseases like cancer. We've referenced some others in our episodes, but we wanted to give some time to better understanding the area of dementia, both for people living with it and for, of course, their friends and family as well.
And I'm really excited that you have joined us today, and I'm really looking forward to this conversation. But I'd like to begin where we like to begin with our guests too, and that is the curiosity side of why or how you ended up where you are in this particular field. And maybe I'll start, Sarah, with maybe some of your background in terms of, we've heard the bio, but what is it that actually drew you to this area of work in medicine?
So I knew that I wanted to be a doctor since I think I found out it was something you could be, which was probably around the age of 5. And I always knew that I wanted to work in healthcare and that having a life of being able to help people and make their lives easier to live was just sounded like a great a way to be. I thought I was going to be a surgeon for a brief period of time and then realized that I really enjoyed the relationships of talking and developing and learning from people and helping them, and may not necessarily be able to fix something, but sort of just having that relationship, moving them along in their trajectory. And so through my medical training, I knew I was going to do internal medicine. And when I became aware of geriatric medicine, which is sort of the care of older adults, and all the things that come with aging, that was something that really spoke to me, because not only do we have to know sort of all of the medical systems in the body and what can go wrong and what can go right, but also the person that is living with all of these things and having a real focus on quality of life and holistic care and, you know, the social environment and the people that are in their lives, not just the diseases or conditions that they're living with. And so that was something that really attracted me to the area, and it's been wonderful. And sort of within the niche of geriatric medicine is a real focus on, you know, cognitive changes that can come with aging. And I've had the opportunity to be involved in, you know, some wonderful work around dementia and cognitive impairments in this area, and have been lucky enough to be part of a research group looking at, you know, clinical trials for treatments for managing and ideally curing dementia as we move forward, but in the meantime, helping patients and their families through this.
Wow, thank you. And Jill, how about you?
I was really fortunate when I was 16 and I was looking for a summer job and really didn't have a particular job in mind, that I got an 8-week contract position at a long-term care facility in Prince Edward Island, where I'm from. And I really had no idea going into it whether I would like it or if it had anything to do with where I'd want to end up in the future. But it very quickly became clear that I was drawn to working with older adults. But more specifically, I was drawn to working with people who were suffering from cognitive impairment. I spent a lot of time that summer in their loft unit, actually, for people who had significant cognitive impairment. And where I found a lot of joy in my day was working with people who were quite advanced in their disease, but finding who the person was behind the disease and getting to know who they were through their lives. And I knew at that point that I wanted a career in geriatrics and a career working with people with cognitive impairment. It took me a while to find out exactly what that career path was going to be. I took every course in my sociology degree that had anything to do with geriatrics. I went on and did a postgraduate program in geriatrics, but it ended up being occupational therapy was the route that I went down. And it took a while to get where I am, but I've been here at the Kawartha Centre. I worked with people with cognitive impairment in my first job at the Northumberland Hills Hospital, but I've been here at the Kawartha Centre for over 15 years, and certainly I know this is where I'm meant to be. And just like Sarah said, what I love about working with these people is getting to know who they are beyond the disease.
Well, I just want to say thank you, and that on behalf of Red and I, who are both older adults, I leave Julie out. We want to thank you that you are there for us along this journey as we find our way in that upper end of life.
Well, and thank you, David. What a treat to be included. But I think, thank you guys. It's funny how we all get to where we're going eventually, isn't it? Some of us know right from the start, and then others sort of make our way there. But nice, good stories is how you found yourselves being in the places that you are.
Yeah, very touching.
Yeah. Before we dive in too far, though, I'm hoping that we can do just a little bit of clarifying, because some of the terms maybe are misunderstood or a little bit confusing, because I think sometimes we use dementia and Alzheimer's interchangeably. People will talk about being senile or senility, and I'm not sure if everybody understands the difference in those types of terms. And so I'm wondering if we could spend a little time making that clarification before we start down this conversation.
So there's some confusing nomenclature when we think about cognitive impairment. So just to give a bit of glossary of terms. So cognitive impairment, so cognition refers to memory and thinking. And so cognitive impairment means there's been impairment in memory and thinking. From sort of a medical classification system, we call things like a major neurocognitive disorder, sort of colloquially known as dementia. And dementia, you can think about it as an umbrella term, which means that there's changes in memory and thinking that are more than normal aging that now has an impact on function. And there's many different types of dementia, with Alzheimer's dementia being the most common type. So Alzheimer's is a type of dementia and probably makes up about 70 to 75% of all dementias. There's also things like vascular dementia, Lewy body dementia, frontotemporal dementia, alcohol-induced dementias like Korsakoff's, and sort of a mixed dementia. So think about dementia as the umbrella term, and then they all kind of fall under that. We try to stay away from terms like senile and senility these days, and as well as away from demented. It's a person living with dementia, a person living with cognitive impairment. So hopefully that clarifies some things.
You were talking there Alzheimer's and these different types, right? So what differentiates maybe Alzheimer's from one of the other types of dementia?
Great question. So a bit nuanced with it. A lot of it is sort of clinical diagnosis of how somebody presents and sort of the history of their memory changes and other things that you might glean from a medical history, supported by cognitive testing, so kind of pen and paper testing to see what areas of memory and thinking are affected. Typically in Alzheimer's dementia, we see changes in short-term memory affected early in the disease course, may have some language impairments, and then sort of over the course of the disease can have impact on all the cognitive domains, which are things like executive function, which is sort of planning and problem solving and sequencing and visual spatial reasoning of how we sort of make mental maps around our space and time. And it tends to be a progressive disease. So it may be sort of small things that are seen in the initial beginning of difficulty with finding the right words you want to say, or names of people, or details of events, and sort of over time, family or friends start to see more and more changes and then impacting function. Whereas something like vascular dementia can be, following a stroke or a bleed in the brain, or somebody with significant vascular disease. Lewy body dementia typically presents with Parkinsonism features and sometimes hallucinations, and less likely to have memory impairment early on. So there's quite a classification system that we go through in terms of making an absolute diagnosis that typically happens on brain biopsy at time of autopsy, which we don't typically do. In a research setting, we have specific criteria for making a diagnosis of Alzheimer's dementia that we don't necessarily utilize in our regular clinical work, because we have access to additional biomarkers with specific imaging of the brain and looking at specific proteins in the blood and the CSF. This is sort of a developing area of work that's probably going to become more mainstream as we find better biomarkers for detecting the disease. But right now, that's sort of within the research world. So sort of for the general population, it's a lot of a clinical diagnosis, which means the history supported by imaging and collateral information from families that helps us make it. But when you look through the data, I think, we're right about 30 to 60% of the time when they actually go back and correlate it. So certainly can be a mixed picture.
What are we talking about in terms of how widespread are we talking with dementia? Let's use that umbrella term. It seems to be one of those pieces that everybody hears. It seems that we have somebody in our family who's been diagnosed or we're connected with, but what is that like in terms of the scope that we're talking about?
So it's increasing. Dementia is typically a disease of aging. So the longer we live, the increased risk we have of developing it. And as you sort of go through each decade after about age 60, our risk increases substantially. There are early onset forms of dementia, which we won't get into today. We'll sort of talk about dementia in later life. But the data as of now is, as of January 1st, 2024, approximately 700,000 people in Canada are living with a diagnosis of dementia. And every day, more than 350 people develop dementia, which is more than one person every 15 hours. And it's estimated that by 2030, about 1 million people in Canada could live with dementia. So it's out there, and it's, as we develop treatments and modalities to help us live longer, this is something that potentially comes along with it. And so it's making sure that we're aging healthily.
So interesting. So I have so many questions going through my head. One of them that just kind of popped in is I have clients who very commonly reference, I think who, especially during the grieving process, because we know that there's a natural fog that happens in our brain, cognitively and with our memory and our attention when we're grieving, and in lots of other instances, and when there's high stress in our life. And so I hear clients reference very frequently. I think I have dementia, or I think something's wrong. How do we start, for those people who worry about that, how do we start to tease that apart as to whether that should be a conversation that they're having with their primary care provider? Or what if they don't have a primary care provider? Where do we start with that?
Well, I think that you've nailed another problem, is the lack of primary care providers. But I think that we're very lucky in our region to have as many opportunities available to people that are concerned about their memory. And it is a teasing apart, Julie. When we have a referral here for someone who's concerned about their memory, they're coming in and they're seeing one of our assessors for 2 hours. And that's just laying some of the groundwork for then when they come back in to see one of our geriatricians for another, usually close to 2 hours, because it isn't a diagnosis that comes with, you have a blood test and it confirms a diagnosis, or you have a CAT scan and it confirms a diagnosis. It takes a lot of teasing apart. And it wouldn't be uncommon, and Sarah can comment on it too, of people who where we do get referrals where someone has noticed a decline in their memory, but also may mention in the referral that they've lost a loved one in the last little bit. And we would often maybe put off their initial assessment for a little bit of time, because certainly grief does cause lots of fogginess and can look like a memory problem. That being said, though, and you can add in, Sarah, I think that if people are concerned about their memory, they do need to bring it to the attention of their primary care provider as early as they can.
What are some of the first common things that people might be seeing? What are some of the indicators where, oh, that's maybe just common, we all experience that, versus, oh, okay, so maybe that's something to bring to someone else?
So this is where we sort of, really dive in to get the history and collateral history, because in the diagnosis of dementia, you have to eliminate other contributing factors. So, if there's substance use, alcohol use, that can certainly impact our memory and thinking. If there's certain medications that can cause some mental slowing, that needs to be addressed. If there's unmanaged mood disorders, so if there's, anxiety or depression, both of those things can impact our ability to concentrate and attend to things, which can sort of mimic changes in memory and thinking. And then we want to rule out other medical things, like, is there something else going on in the brain, or thyroid, or low vitamin B12? And so teasing all of that apart and then getting to, what's actually going on. And there are cognitive changes that happen with normal aging. And so, if you have difficulties with, the tip of the tongue phenomenon, we talk about I was looking for the word I wanted to say and it didn't come out. And then later at night, I woke up and it came out. Those things can happen. It can take us a little bit longer to sort of learn new information, but, stuff that sort of has been built into us, we should kind of keep with us. It can be a bit harder to sort of multitask. So if you're used to, being on your phone and answering emails and having phone calls come in and visitors and, trying to manage 5 different things at once, as we go through the decades, it's going to get harder to sort of be able to attend to all of those things. When it starts to be a little bit more than normal aging is, when we're forgetting details of events, forgetting conversations that we had with people, more of the word finding difficulty, and the words are not coming back to us. Difficulty with remembering names of people that we should see. If it's somebody that you've, saw the last time 10 years ago and they see you at the grocery store, it's okay if we forget their name. But if we're starting to have difficulty recalling names of people that we see quite regularly, that might be a sign that things are changing. If we're having difficulty keeping up with our tasks of day-to-day life, those are signs that things might be changing and we need to have an assessment.
When you're seeing that, I was thinking that's sort of from an outside objective point of view. And I know you can't speak necessarily for the individual who might be at the start of a diagnosis, let's say. But I know I've had family members, and I've heard this before, where when you know that this is happening, and then there's the phase where you might not know, where it progresses. From your experience, do you have any sense of what that journey is like for people? Like I had a family member who went through that, I know, and then they went through like an angry phase, and then they went through a violent phase, and then they got really docile. And you could sort of watch that individual go through those phases. But from your experience, is there any sense of what that's like as the individual, what they're going through?
I think that it's very different from individual to individual, because even in the early stages, there are lots of people who are completely unaware that they have a problem.
Okay.
There's that whole idea. If you can't remember something, you don't remember that you didn't remember. So you will have some people who are completely unaware that they're having any issue whatsoever, but they're trusting their family who's saying that there is one. Then there are people who are unaware and they're not happy with their family who believe there's a problem. And then you have the people who are acutely aware that there's a problem. My mother also suffered with dementia, and she was completely unaware that there was any issues. She at no point felt like she had any memory problem, that there was any issues whatsoever. And I thought we were all the ones with the problem, that we were concerned. But she would forget, even when she went to the doctor about her memory, she would forget almost immediately that there was a problem. So there's that type. And then you have people who are acutely aware there's a problem. And that's where those are the people that feel the real losses along the way, because they are so aware.
I know, Jill, that you have been close to people who have been in that scenario, and witnessing their grief around that journey.
Absolutely.
And so there must be a certain depth of sadness for that individual.
I'm going to go back quickly to my mom. My mom had issues, certainly, that were very upsetting to her through the course of her disease, but at no point did she grieve the loss of her cognition because she didn't think she had a problem, to the point that she had a memory assessment one day. My sisters had taken her to the appointment, and she talked to me later on the phone, and I said, "How did you get along at your appointment?" And she said, "Well, good." And I said, "Well, what do you mean by that?" And she goes, "Well, they asked me all these questions, but I got them all right." But we know she didn't, and we knew the score she received on the assessment. But if you were to ask her, she was answering the questions, so she assumed she got them right. I have another lady that I see here regularly, and most of her answers are wrong, but she answers them with such confidence. I could ask her in the middle of July what season it is, and she can say with confidence it's winter, and she walks out of my office assuming that she has, gotten 100%. But then there's the others who, they know every step that they're wrong, that they are losing something, that they're not the person that they used to be.
Yeah, the loss in identity, right?
And I think because this disease can affect so many different ages, like we have patients who are in their 50s that get diagnosed, and we have patients that are in their 90s that get diagnosed. And, we're at very different life stages kind of along this spectrum. And so we have patients that have, been actively working and are now having to give up working responsibilities because of the changes in their memory and thinking. And, that has been a real loss. And when there's other discussions about things that they're needing more help with, typically there's discussions around driving safety and whether this is going to be something that needs to be reviewed, in the loss of a driver's license and the independence that comes with that. So there's sort of these, whether or not they even have, insight or not to it, sometimes they're faced with these losses that I'm no longer going to work. I'm no longer able to drive my car. I'm, no longer able to do these things on my own that I typically was doing on my own. That comes, and that's a loss. It's, a sense of independence that they grieve in different ways. Sometimes it's sadness, sometimes it's anger.
It seems to me that just listening and realizing that those losses can be part of all aging experience. But with the dementia, it compresses them into really dramatic loss at a very time. I'm wondering, and before I forget, because I was thinking earlier, I don't want to forget the question about familial. Is this a dementia something that does run in family? Because I often am asked that question. My parents, my grandparents had Alzheimer's, so I guess I will too. Where does that lead?
So in the early onset forms of dementia, and I'm talking about types of dementia that people develop like in their 30s and 40s, there can be very strong genetic components with an autosomal dominant inheritance. These are not the patients that we are talking about. In sort of the later onset dementia, sort of, in the fifth, sixth, seventh, eighth, ninth decade of life, there are some genes that are associated with a higher risk of developing dementia. We do not typically screen for these genes. They are sometimes looked at in clinical research trials. And if you do the 23andMe and DNA testing on your own, sometimes they can come up with that, but it does not necessarily predict that you're going to develop a dementia. Sometimes we do see, families where a whole cohort of siblings will have it. Typically, these are families where they're developing them maybe a little bit early, like in their sixth and seventh decade. To say my grandmother and my aunt and all these people developed dementia, but they were diagnosed at age 96. That's not necessarily, a strong hereditary component.
Mm-hmm. What do we often, the larger we, get wrong or not understand about dementia? Or what are you hear some of the common myths or the things that maybe we get wrong even in supporting or responding to families living with this disease?
I think one of the things that comes to mind for me is that this disease has a trajectory, and so the diagnosis does not mean you are heading to long-term care soon. You can live very well with this disease, and lots of people do. So I think that if people they don't have a family member or someone that they know well that has the diagnosis, there can sometimes be an assumption of what that diagnosis looks like and how people will present and what they'll be like. When in reality, probably everyone is interacting quite frequently with people with this diagnosis, and they have no idea that the person has this diagnosis, because they can still carry on the conversation in a social situation and do all sorts of things and drive to their euchre game and do all of these various things without anybody even being aware. So I think sometimes there's just an assumption that once you have this diagnosis, you are a certain way and you're going to present a certain way.
When I'm doing my discussion with patients and their family or care partners or friends, when I disclose the diagnosis of dementia, I usually frame it in you've had changes in memory and thinking that are more than normal aging. We're starting to see impact on your function. We call this a dementia. And then I say, have you heard this word before? And then I say, what does that word mean to you? Because some people say it means I'm going crazy, or it means I'm going to long-term care. It means I'm not going to be able to drive my car anymore. And so they, can have very strong emotional attachments to this word, depending on what their lived experience with it has been. And so getting a sense of where they're at with what that word means, I think, is really important. And just like Jill said, you can do really well, with this. And it's this sort of idea that just because we have this diagnosis, it's, making sure we have the supports in place to allow you to be as independent and enjoy the things in life that you want to continue doing in the best safe way that we can.
What about the experience of the family or who they identify as family?
I think that also can be very different from person to person and the experience that they're going through. I had the opportunity to spend some time with a lovely care partner this afternoon who is still quite young. Her husband got diagnosed very shortly after retirement, and it was an early retirement. and they are still having grandbabies. Like, their daughter just had a baby. Meanwhile, her husband is, by the end of the day, doesn't necessarily always know who she is. They're heading on a trip and to visit their daughter who had the baby, and she's nervous about the trip because she knows it will increase his anxiety, it will increase his confusion. But at the same time, she's feeling, but my daughter just had a baby and I need to be with her. So it's a difficult situation. But what she said was, but she said, he's just so meek and mild. She said, he never, I can just say, no, it's okay. Everything is going to be okay. And he'll calm right down. So that's their experience. But others, that may not be the case. I have another situation of a wonderful couple who he has just worked so hard at maintaining his independence, and little things can really upset him now. Like when he goes to do something that he's always done and he does it wrong or forgets an important component, and she kindly reminds him, he's now getting very angry over something that's quite minute. So the experience for a caregiver can be very, very different, and also depending on the stage of life they're in. Dr. Brisbin mentioned, some couples that are fairly young. So where you really see a lot of loss there and difficulty for the care partner is the loss of their partner, the loss of their person who maybe can't make decisions with them like they used to. That maybe the fact that situation where that care partner has always booked their travel. So they may still get to travel, but now the spouse is having to learn how to do something that they never did. Or they're having to look after complex finances, but that was never their role. And they've always shared. They've always made decisions together, and now maybe that their loved one just can't make decisions like they once could. So there's I think there's early on, there's that real period of grief that sometimes settles a little bit, and then it comes again when they move on to the next stage of the disease.
And I've been wondering whether or not to introduce this idea, but I would like to hear from both of you in terms of a comment. One of the challenges that we come up against in a palliative context is often the inequity of the healthcare system for people who want to, let's say, look after someone in their home. So again, as you said, Jill, that jump to, I'm going to go to long-term care is often that sense of there isn't enough support to help me keep somebody at home. And that inequity, we see that in the challenge of getting nursing and enough support into the home to do that. But I get a sense, and maybe I'm wrong, but I get a sense that there may be more of a willingness on the system, the health system, to maybe fund more care for cancer palliative patients than necessary dementia patients. But I don't know that for sure. I'm just asking, what do you see in some of these inequities that really make it difficult for families when they want to care for somebody?
Oh boy.
Dr. Brisbin?
The system has made things very challenging for allowing people to age at home in the way that they would like to be, and maintaining as much independence as possible. The reasons behind this are quite complex, and I don't think anybody has a great answer for them, but obviously that, people and support and resources and funding kind of generates a lot of it. I can't speak directly to, how things are funded differently between palliative home care and the home care that we get for our patients, but it can be very challenging. Like typically a cutoff mark is, whether somebody can bathe themselves. And so as long as somebody can get themselves into a shower, they don't qualify for certain types of home care, or they're having to do private pay home care supports. And so, to have people managing this on their own or with a care partner or friend or family member, like it's struggling until you get to that next stage where you really qualify for it. And we could bolster this system. I think people could do so much better for longer, and we could delay the transition to a long-term care home, or the presentation to the emergency department and then going into hospital, because the caregivers have just had it in terms of being able to support everything themselves, because it's quite a job. And I think, there's a concept of postal code medicine that depending where you live, you have access to more resources. I think that is true with all of this. Certainly our patients that are living in more rural and remote areas have very limited access to this. Some of them can't get any access to home care support. And so it's basically, once the care partner and families are no longer able to manage things, then it's hospital or long-term care, and our wait lists for long-term care in the realm of years. So it's a broken system with lots of work to do.
What do you see are the general sort of, I always call them deal breakers, you see, when families are no longer able to manage at home? What are some of the common circumstances that would bring a family to that point of that decision?
I think there's a few things. One of the more common ones is, people living with dementia have higher risk of developing incontinence with bowel and bladder for a variety of reasons, of the signals that tell you that I need to go to the bathroom, and then making the motion to go to the bathroom and being able to clean yourself up in the bathroom can all become impaired as the disease progresses. And so having to provide kind of personal care with bowel and bladder and incontinence can sometimes be very challenging for people. People living with dementia can develop neuropsychiatric symptoms of dementia, or behavioral psychological symptoms of dementia, which are kind of changes in behavior and personality, which can be mood symptoms like anxiety and depression, but can also develop psychosis, so hallucination, paranoia, delusions. And some of these can be quite distressing, with a lot of paranoia, yelling, hallucinations, calling the police, which can be challenging to manage. And we try to optimize that as much as we can with non-pharmacological supports and sometimes pharmacological supports. But sometimes it gets to a point where it may not be safe for that care partner to be at home, and that we're just needing more support than is able to be provided. So those can sometimes be tipping points.
Also, the caregiver also can play a big part if they're dealing with any health concerns themselves. And it may even be as simple, because people with dementia often will develop issues with mobility. It may be simply that the care partner can't transfer them. They're willing, they are okay to do the personal care, but they physically can't do the transfers by themselves to in and out of the bed, in and out of the wheelchair, on and off the commode. So it may be just because, for their own physical reasons, be it health issues or just, their loved one is a larger person that's heavier lift. It may just be that they physically can't manage anymore.
Right. Is maintaining your mobility also potentially a safety risk? Because I can remember in the hospital there would always be folks that were wandering and seeking exits, and we would have to then go find them in the community, and they'd be kind of lost. So there's sort of like losing mobility, but maybe also maintaining mobility and wandering. Is that a common sort of deal breaker?
So ideally, I'd want to maintain mobility as much as possible.
Yes, oh, absolutely. Yeah, but sometimes
it's doing it in a safe way.
Exactly. Yeah.
To make sure that we're not leaving the home in the middle of the night, in the middle of the winter, and things like that. And so these are things that we discuss at our appointments, and risk mitigation. So things like door alarms, wander alerts, registering with the vulnerable persons registry, and sometimes families will use things like trackers to make sure they know where people are. So yes, we want to maintain mobility, but it's doing so, in a safe way.
Right.
And I think, getting back to sort of other reasons, which may be a tipping point, is sometimes there's not a care partner. Like, sometimes it's a family member that lives far away, or it's a friend next door that's been managing things. And so, sometimes it's the lack of support from friends and family, not by any specific circumstances, just, a spouse has died or divorced or single or just contacts available.
Part of where I have been more involved as a therapist with families is helping them process the guilt when they have to make that decision. And even though, logically and rationally, there's lots of very good reasons why they've arrived at a place where we may have to look at an admittance to long-term care, that guilt is often very weighty for them.
I think you're absolutely right. And I think I see it, and Dr. Brisbin, you may see something different. I think you see it more often when the care partner is a spouse, because there's a little bit of that till death do us part. And I also feel, I've heard several people say, he takes such good care of me. This would be the person with the disease saying, they take such good care of me. I don't know if I could could have taken such good care of them. If the shoe was on the other foot. So I think there's often just that, they're my spouse, this is my job, this is what I'm supposed to do. So then, of course, there's going to be a heavy guilt when that time comes.
Yeah.
The guilt is big. A way that I try to frame it also is that you've been the spouse or the friend or, child, as well as, a nurse and caregiver and social worker and all these things that come with being a caregiver. And when you have the transition to long-term care, sometimes you get to just go back to the family member. And there's other people that are able to kind of help fill that role. And you don't have to be the one doing the heavy lifting, literally, figuratively anymore. You can be there for the visits and, enjoy that time rather than having to manage all these things and worry about safety and things of that nature.
I just wanted to comment, when we did this recording before, I had given several quotes from a care partner who had done a lot of writing during her caregiving journey. And I was looking over that stuff tonight. And I'm just going to read a little paragraph that she wrote when she made the decision that her husband had to go into long-term care. It was very, very challenging for her. And I think also it's interesting to note that she worked in long-term care and then had to make the decision that her husband had to go there. But what she wrote was, "It has come to the time where he must go and live elsewhere, where others will care for him, and I am panicked. I am heartbroken. I don't think I'm ready to relinquish my wifely and house guide duties. My heart is heavy, and every time I think about his going, I'm in tears. He'll be so lonely. I'll be so lonely. I've been with him since I was 15 years old, and we've been married over 40 years. I also know that to a certain extent, this woman did get to a place of just what Dr. Brisbin said. She did get to be with him in a different way after he went to long-term care, because she didn't have to do the personal care and she didn't have to do some of those things. But in that decision-making process, that it's time, I can't do it anymore, I think she very eloquently says how she feels.
I think that stands out so much with me in terms of, while it's true with any disease, but with the dementia, it's so much more than just a medical response. It's a psychosocial, the angst, all of those pieces of our humanity that need to have full attention. So, it's not just a matter of the right pill here or there, but this disease demands a real focus on our humanity and what this is doing to us as a person and to our families, what it's doing to them as people and as families. So I love that you did a sociological degree, because I think that plays into our need to care for this piece of this disease.
Well, I think that's so important. These people do feel so much loss. So it's really important that those that are supporting them, working with them, both, family members and professionally, is seeing who that person really is.
Mm-hmm. It kind of reminds me, and I'll get the title wrong, but I think it's The Boy, the Mole, the Fox and the Horse, that book. And the boy asks the horse, what's the bravest thing he's ever said? And the horse replies, help. He says, people think when you ask for help, it means you're giving up. He says, asking for help means you haven't given up. And it's just that little twist. But we sometimes need help to be able to carry on. And if we're carrying on, it means we haven't given up. And for me, it's a neat little phrase that just in a little kid's book that just sort of nails it. That says, yeah, sometimes you have to have help to carry that weight and that load.
Absolutely.
And for the individual and the family.
Yep.
Absolutely.
Well,
Yep.
Right. The family.
Yep.
And I'm putting you on the spot, Jill, but I was wondering, as a family member yourself, is there anything you would want us to hear about the experience of you and your family going through the process that would help us understand what it's like for families?
Oh, sure. Where do I start? I think if I were to look back on Mom's life, so first off, it's amazing how as time passes. So it's been she died in July of 2019. So as time passes, you start to forget about this woman who had a dementia and think back to the woman you had your whole life. So some of the maybe not so great memories and feelings of loss start to dissipate a little bit over time, which is a good thing, because we certainly had more of her without dementia than we did with. But one thing that was very difficult for us to see was my mom was a very social woman. She was very, very involved in the community, very involved in her church. Her and my dad were very social. They went to dances, they went to card games. When my dad, he died of a brain tumor, and all the cavalry came out, like all of the friends came out everybody came to visit, everybody was such a part of that. But when my mom, as she developed in her disease, people pulled away. And, people who, we thought were really good friends of hers just kind of disappeared. And, she didn't have the plethora of visitors that my dad did, even though probably she was the one who nurtured those relationships throughout life. And I think it's because people don't understand the disease. I think it's because there is a stigma and they didn't know what to say if she repeated herself, or she didn't necessarily recognize them right away. I think as a daughter of someone who had dementia, that really kind of still stands out. Stands out to me.
Yeah.
And the other part too was just the loss of our mom. Julie, you knew my mom, and you know what kind of person she was. If you had a good day, you had a bad day, you had something exciting happen in your family, you're having a hard time with your kids, all of us, all five of us initially, immediately called Mom. And as time went on, the inability to share that stuff with her because you weren't going to get the response you needed because she just didn't comprehend it the same way, or she'd have trouble keeping track of the information. And that was really, really difficult. But I do think it's also important, even since we last recorded with you guys the first time, which it was probably about a year ago, how those losses are really dissipating and more of the focus is on who she was as a rest of her life.
And thank you for sharing that. And I think it resonates with those of us who've gone through that journey as well with a loved one. I also recognize, because I just had an experience with a dear friend whose partner has lived with Alzheimer's had lived with it for about 4 years, but they had developed a real village, and that's what they called themselves, was a village of support, of friends who every day would connect, every day would be there, every day. But that's I wish it was more prevalent. I think it's a very rare gift that some families have. But if they do, and I love that, what you said there, Jill, about, often we retreat from what we're afraid of. And rather than that, can we find a way to be connected and maybe deal with our own fears of what keeps us away? And, it's amazing that how much magical thinking happens where people are, they move away when they don't understand, or they move away because they're afraid they might get it. All kinds of crazy things that keep us from being truly a village of compassionate people.
To add to that, though, David, it's interesting. One of the assessments that I do in the clinical trials is a quality of life assessment, and I have to ask questions of the participant and also of their care partner. And one of the questions is like, their friendships, like, what's the quality of their friendship? And it's amazing, though, the comment that I most frequently hear is the quantity has diminished significantly, but they're the ones that have stuck around, it's quality.
Wow.
So
Good.
Yeah, so it may be that they had, a group of 10, but now it's down to 2, but those 2 are really sticking by and offering. So the amount of times I hear that the whole like loss in quantity, but certainly still some quality is.
Yeah, that's encouraging. Yeah.
I'm so, I have all these emotions I'm feeling about. I feel so sad to hear that story, to hear that, when you spoke about your mom and your dad, Jill, I feel this like real sadness, but then I hear like the beauty of the hardiness of like those, when you say, it's from 10 to 2, but then I feel this like real beauty of those 2 people.
Those 2, yeah.
Those 2, right? I was like, oh gosh, I'm so thankful though they have those 2. And the quality of those relationships and the quality of those people.
And that's not everybody's experience. Certainly lots of people, they have their village, they have their entire communities that just, jump in and help out.
I wonder if I could just change the direction a little bit here to just kind of ask, so you're in a unique situation in where you both are involved in every day in the clinical side, and it's really a significant place. Maybe you can help me understand how unique it is where your clinic is. But what are we learning about this? What are we learning that's helpful? I mean, I heard the other day, and I don't know if this is true, but this link between, say, concussions and dementia later in life. Because we're living longer, we're able to do more research, perhaps. But what are some of the things that you are discovering in these in the work in which you're doing?
Well, I think there's a couple of different directions we can go here. Sarah, I'll talk a little bit about clinical trials, and then maybe you can comment on some of the other learnings. But I started working here 2008, almost 15 years. And I was working on our clinical trials right from the very beginning. We're a research site that is trialing clinical trial drugs for Alzheimer's disease. So these are international trials. So we're just one of the sites that's involved in these trials. And I often describe it to people that when I started here, it was as if someone had taken 1,000-piece puzzle and threw it on the table and said, okay, we got to figure this out. And all the pieces were upside down and all over the place. And, they were trying all sorts of things, but it just didn't feel like we were getting very far. Now I feel like, oh, look, we can see we've put together all the edges, all the corners are together, and there's some pieces coming together on the inside. But boy, there is still a lot of pieces that have to get put into place. We've probably the last 3-4 years, we've probably seen the most advancement, certainly if you looked at the last 20 years, but we still don't really know what's the cause, what is the actual target that drugs need to attack. Do we need to be looking at multiple things mixed together? So there's a long ways to go, but certainly we've seen a ton of advancement.
So what makes up the edges? What are the advances? What's the research to this date telling us that we didn't know before?
Well, just to give a couple of small examples. When I first started, we had drugs that were focusing on a certain protein in the brain, and that is believed to, build up and be part of the contribution to Alzheimer's disease. So these drugs were being administered to people to help remove this protein that was aggregating together in the brain. But at that particular point in time, they didn't have a test to determine if people actually had that buildup. So you're giving the medication, but maybe their diagnosis wasn't Alzheimer's disease and their protein buildup wasn't there.
Right.
So of course those drugs were failing. Well, now they're testing very similar drugs, but they now have the ability to do PET scans and testing spinal fluid to determine if people in fact do have that protein.
I see.
Right.
They also, a lot of the original drug trials were looking at people who were fairly advanced in the disease, and probably by those particular drugs that were being tested, part of the problem may have been that the disease was too advanced. So now we're actually having drug trials that are looking at people that don't have a diagnosis of Alzheimer's disease yet, but it appears like they very well may develop it in coming years. So trying to attack the problem before it gets too large. So, those are just kind of two very basic ones, but big ones, like very.
Yeah.
Yeah, I think part of the challenge has been that we don't really know what causes Alzheimer's. There's hypotheses that we're working with and that a lot of the drugs are targeting. But because of some of the failed trials that Jill mentioned, we're sort of expanding our network of what we're looking at. Of all the systems in the body and diseases that have been studied for a long time, it seems like dementia and Alzheimer's disease continues to remain this elusive beast that hasn't had some of the successes that we've seen in understanding various cancers and developing wonderful new treatments for them. So unfortunately, we don't have a cure for it at this point. We're starting to see some, maybe rumblings of data that shows a little bit of positivity and some hope. It's probably not going to be a huge game changer, but it's a piece of the puzzle that we're going to have to continually build on. And the things that we have learned, aside from medications that are helpful, are some of the non-drug things that are so important. So like you said, the connection between concussion and dementia down the way. So, there's something called chronic traumatic encephalomalacia, where we're seeing people who've had repeated head injuries can go on to develop cognitive impairment later in life. And that sort of prompted, better concussion protocols in the NHL and NFL and requirements for helmets, understanding how important it is to protect the head. Other things that are important are, maintaining healthy diets and making sure things like diabetes are managed and blood pressure are well managed, and staying physically active, starting in early life and continuing all through later life, and staying socially active, which is such a big piece. And there's a lot of emerging data out about social isolation and loneliness having the same morbidity as smoking for 30 years, which is wild. And it's interesting hearing Jill talk about your mom with sort of the village pulling away. And I experienced the same thing with my grandmother who had Alzheimer's disease, where the whole group of friends kind of pulled back because they didn't know what to say or how to act. And this is probably one of the very few diseases we have where that social interaction is like a treatment. We're going to see, your friends that are living with this can actually help them with that structured social stimulation and, staying engaged in your community and learning new things through life. And so, we're learning a lot about risk factors for dementia, like, education in early life, smoking history, drug history. Hearing loss is a huge one. Hearing loss is probably the number one modifiable risk factor for dementia, because if you can't hear information, you're not going to remember it. And so, making sure that we're having early hearing assessments done and trying just to maintain all of these things in the background while we continue to work on medications that will be helpful for the disease.
So can I ask you both, and this may be a strange question, but are you hopeful?
I am.
Yeah.
I've seen enough change in the amount of time I've been working in this industry to be hopeful.
I am hopeful as well.
Fascinating. So fascinating. As we begin to wrap up, I'm wondering if you could comment on how has doing this work, working with patients and their care partners, their families, changed you? What has it taught you?
So you bring this up at a very interesting time, just because of some other work we're doing with our patients and caregivers right now. But I've had an opportunity to had an opportunity to attend a conference in the States a couple of weeks ago, and there was a lot of focus there on, really recognizing the people who contribute to clinical trials. And I think for me, Dr. Brisbin works in clinical trials, but also sees patients who are just coming in for assessment. So my experience is almost all clinical trials right now. I am in awe of the people I work with every day. The patients who volunteer their time and the caregivers who support them in the journey. I am in absolute awe. I rarely go a day that I am not just touched by their dedication and their attitude. I spoke to a gentleman today about a kind of a recognition award for participating in clinical trials. And as I was talking to him about it, I said to him, I have to write it down. He looked at me and he goes, but as a citizen, isn't it our responsibility? So these people who just so freely give of themselves and their bodies to help promote science, it's very humbling.
It sounds like the words that came to my mind as you were talking is like you're seeing the beauty of our humanity.
Oh, absolutely.
Of who we can be to each other.
Absolutely.
For me, I think, it's an honor and a privilege to be part of these patients and their families' lives, to be through them, through the journey with them. And sometimes I'm their worst day of coming to get this diagnosis. It's something that they're fearing. And the day with me is kind of the day that things changed. And, that's a huge responsibility. And I take it very seriously. And we may not cure always, but it's, comfort always. And it's an honor to be part of that and to really find out who they were and making sure that we continue to focus on that.
And I think that's part of it too, Sarah. And I think you just said that very well. This is such a different disease and diagnosis than some. Because you have to really dig into these people and who they are and what their background is and what their day is like. And you get to know them very intimately. And the fact that people can let us in and let us be part of that is very, very special.
That's a good place to end, I think.
Yeah, thank you so much. This is very, very helpful and meaningful and touches me deeply. So thank you.
That's how I feel. I feel like I've learned a lot and I've been touched many times throughout the conversation. So thanks to both of you.
Yeah, thank you.
Yeah. Having us.
Thank you.
Thanks so much.
Thanks for listening to What Now? On the Threshold of Life, Death, and Grief. What Now is produced in partnership with Hospice Peterborough. Music by Paradise Garage and technical support provided by Sean Heichert. What Now is recorded at Thin Space Studio. You can find more episodes of What Now for free on major podcast platforms, including Spotify, CastBox, Apple Podcasts, and Overcast. If you want to support us, please follow and leave a 5-star review wherever you get your podcasts. And tell your friends. It does make a difference.